Good evening, everyone. I welcome you again in another session of 4D 2.0, that is detailed discussion in diabetes and its complication. We have come up again with a very interesting topic of diabetic foot and its complications. Diabetes, as we all know, a disease that is associated with complications, and diabetic foot is one of the most problematic complications of diabetes because not only it is associated with significant morbidity but significant amount of mortality as well. The amount of economic burden that it puts on a patient is huge because not only the patient has to spend a huge amount on his or her treatment, but also because of the foot complication, the patient is not able to do his work as well. So it is a double edged sword as far as patients are concerned. So today we have a very experienced speaker with us, Dr. Vidhya Jahagirdar from Coimbatore. She is consultant endocrinologist at KMCH Coimbatore. She has over 10 years of experience in diabetes and endocrinology. She obtained her MRCP from UK and again the specialization certification, that is CCT, again from UK. She has been trained at various centers of excellence in United Kingdom, and she has several awards for various presentations at national and regional conferences in the UK. She is very frequently invited as faculty for various national and regional meetings in India. She has special interest in metabolic bone disorders, and she has keen interest in women's health as well. Currently, she is involved in rural outreach program in association with the Rotary Club and IMA. She is also involved in creating awareness about diabetes and hypertension. Dr. Vidya, thanks for joining us for this meeting. Over to you.
Good evening, Dr. Atul, for your words of kind introduction. So today I'll be discussing about a very important complication of diabetes that we don't often about. We talk about macrovascular complications in a very broad sense. Today we'll be focusing on diabetes and how it could lead to different food complications. We very well know that diabetes in India is on a very steep rise, and the prevalence is about 9.6% among adults over 20 years and above. So it's not very uncommon that we come across type 2 diabetic when they are in their 30s or 40s. In India, 1 in 11 adults are living with diabetes, but the sad part is that more than 50% of them do not know that they have diabetes. And the number of people with diabetes in India is the second highest in the world. So we will, I will not be surprised that we come top in the world if we do not do much about lifestyle changes or prevention of diabetes. There should be strategies and policies implemented to prevent diabetes in our country. Why does the food complications occur? Prolonged hyperglycemia obviously is one of the reasons that has been attributed to food complications, like many other complications of diabetes. But what is a huge spectrum that we come across is that peripheral neuropathy, peripheral vascular disease, leading on to foot ulcers. There's a higher risk of sepsis, poor wound healing, leading on to limb amputations. So it's a huge spectrum that we come across in our clinical practice. Often diabetic foot ulcers are preceded by diabetic neuropathy. Up to one third of our patients could have diabetic foot ulcers sometime during their life. So the different papers quote different statistics, and up to 34% is what the usual statistical score is. 34% of our patients could have a diabetic foot ulcer in their lifetime. And foot ulcers account for up to 11% of all hospital admissions in diabetic patients. So when you look into the epidemiology of foot complications and diabetes, as we said, 14% of diabetic patients will develop foot ulcers, but there are literature evidence to suggest up to 34% will develop the global prevalence is about 1.6 to 8%, depending upon the region. And foot ulcers are more common in type 2 diabetic because of the longer duration and because diabetes goes undetected for a longer period before we detect type 2 diabetes. And that is one of the reasons why I started this rural outreach program along with the Rotary and IMA, so that I can go into the rural area and detect type 2 diabetes earlier and educate them about diet modification, lifestyle, and prevention of complications. So we'll have to make it a point to try and screen everyone who comes into our outpatient, be it general physicians or diabetologists, their relatives who walk in, or they come to see us for any other problem. We'll have to screen them for diabetes. And that is one of the ways that we can detect undiagnosed diabetes, because the prevalence of diabetes, undiagnosed diabetes, as I said in the previous statistics, is up to 53%. Once the patient's had a diabetic foot ulcer, then the recurrence rate is very high. It'll keep on happening over and over for the same patient, and it could be at the same site, same foot, or it could be the other foot where the patient is bearing most of the weight. And the recurrence rate is about 40% within 1 year and 65% within the subsequent 3 years. Based on there are different classification of diabetic foot ulcer based on the natural history or based on severity. So based on natural history, the foot can be absolutely normal, or there could be high risk foot, like patients with foot deformities, calluses, corns, patients who have very dry skin, patients who walk barefoot, patients who have got peripheral neuropathy, smokers. These are all high risk patients and high risk foot. Ulceration, where at least there is kind of a loss of epidermis and at least part of the dermis. This could lead on to infection of the surrounding structures, leading on to cellulitis. They could have necrosis or leading on to major amputation. There's a fungus classification based on severity. The skin could be intact with just a blister or callosity or dryness of the skin, that's impending ulcer. The first stage would be superficial ulcers. The second would be deep to tendon, bone, or ligament. The third would be osteomyelitis. The fourth stage would be gangrene of toes or forefoot, part of the foot. The fifth one would be gangrene of the entire foot. So depending upon how severe the ulcer is, the higher the scoring. So if you look into the pathophysiology of diabetic foot ulcer, about 35% of patients who develop diabetic foot ulcer have got peripheral neuropathy. About 15% have pure peripheral arterial disease leading on to ulcer. And more than 50% have combined neuropathy and peripheral arterial disease. So with peripheral arterial disease, obviously there is atherosclerosis and increased oxidative stress leading on to inflammation in the lower limb, microcirculation, loss of formation of the collateral circulation leading on to ischemia, and these usually happen at the tips of the toes, and this could lead on to dry gangrene. Diabetic peripheral neuropathy could be divided into sensory, where there's loss of protective sensation, motor neuropathy, which can lead to wasting of the small muscles and the deformity of the bone setting. One of the deformities that we do come across but often miss is the Charcot's neuropathy and deformation of the foot, which is one of the major causes of diabetic foot ulcer. Autonomic neuropathy, again, this we'll have to pick up in our clinical practice. We often miss looking at a patient's feet, especially when we start doing a consultation from across the table, rather than making the patient sit on the side so we can see the patient's feet very comfortably. And dryness of the skin is one of the early signs of autonomic neuropathy. There is no sweating, there's loss of hair, and this could lead on to skin fissuring, and this could be the beginning of breakage of the epidermis leading on to ulcer. Loss of protective sensation, again, we'll have to examine our patient, good history taking and examination to understand the degree of loss of protective sensation so that we can give adequate information to the patient to prevent ulcer from happening. Again, prolonged hyperglycemia, oxidative stress, chronic inflammation, disrupted angiogenesis, decreased inflammatory response. All these leads to defective wound healing whenever the patient happens to have an ulcer of the foot because of even trivial trauma, which goes unnoticed because of the loss of protective sensation. There is a diabetic foot risk classification by the ADA. The risk is categorized as very low from a category risk 0 to a very high risk, which is category 3, and an urgent one where there's an active pathology like an open wound or an ulcerative area with or without signs of infection, new neuropathic pain or pain at rest, signs of active shock or deformity, red hot swollen midfoot or ankle, which is often can be mistaken as just cellulitis or osteomyelitis or deep vein thrombosis, but it could be active shock or deformity and vascular compromise. These are the group of patients where you would need urgent active intervention and perhaps immediate referral to a specialist who could look for peripheral vascular disease and create an opportunity for revascularization before gangrene sets in. So if you come across a patient with absent foot sensation or claudication pain, those are the patients we should refer immediately. The high risk category would be patients with previous history of diabetic foot ulcer or lower extremity amputation or chronic venous insufficiency. Those are the high risk patients who should again be referred to a diabetologist with special interest in foot care or to a tertiary care center, and they should be followed up on a regular basis because they are, even if they don't have an active foot ulcer, these are the at risk patients for whom if you do enough for them in terms of education or protective footwear or revascularization, we can prevent ulcers from happening in these patients. Moderate risk, that is ADA category 2, or patients with peripheral arterial disease with or without loss of protective sensation. If the pulses are present but diminished, or you find monophasic flow in Doppler, or if there's presence of swelling or edema, then there is loss of microcirculation. These are the patients again are prone for blisters. Patients with swelling or edema are more prone for blisters, and this, when breaks down, can create ulcers or cellulitis. So these are the patients again should be referred as soon as possible to someone who can address these issues promptly and treat them. The low risk patients or patients with long standing deformity of the foot, like chronic shark cords, which is not really changed, or these patients will have loss of protective sensation. These patients can be managed in the primary care as long as we have given them all the advice to protect the foot and prevent it from getting ulcerated. If they are on appropriate footwear, MCR footwear, or appropriate footwear to offload the pressure points, as long as you've done these, then these patients need not be referred as an urgent case to the referral center. But it's better these patients are with someone with interest in foot care. The very low risk patients are patients with no peripheral neuropathy or peripheral arterial disease, and we just have to educate them on a regular basis in order to prevent foot ulcers from happening. So therapeutic strategies for diabetes management is it's like any other macrovascular complication, is like hit hard, hit early on, use fixed drug combinations if needed, use multiple drugs in order to achieve good glycemic control. So that would be the baseline for any kind of prevention of micro or macrovascular complications. That's not going to be very different for diabetic foot ulcer. The purpose of putting this slide is to just clarify that SGLT2 inhibitors previously was thought to lead to lower limb amputation, but the FDA has taken out that black box warning. So there is no risk of lower limb amputation with SGLT2 inhibitor. Rather, if you use a dual drug combination with the DPP4, SGLT2, metformin, with many drug combinations, we will be able to achieve better glycemic control so that we can prevent complications such as diabetic foot ulcer. So, but there's a slight added benefit of adding a DPP-4 inhibitor. There are several meta-analysis and evidence to suggest that DPP-4 inhibitor, apart from improving the glycemic control, seems to have some effect on local wound healing. The effects being improvement in the endothelial function, the angiogenesis, and the inflammatory markers at the level of the wound itself. So there are several, randomized control trials and meta-analysis to suggest that perhaps DPP-4 inhibitor is a better choice in patients with diabetic foot ulcer because they seem to have some added benefit. So that's the end of my talk. But to summarize, diabetic foot ulcer is a preventable complication of diabetes. We should just pay more attention to preventing a diabetic foot ulcer, picking up the early at risk foot by very good thorough history taking at every consultation, educating a patient regarding prevention of foot ulcer. For us, most of our Indian patients have the tendency to walk bare feet even in the garden or the farm, or they have the tendency to walk bare feet in the temple, or they have the tendency to go on yatras. We need to advise patients who are at risk not to do these high risk habits, I should say, of putting themselves at risk of diabetic foot ulcer, developing a diabetic foot ulcer. So I usually examine my patients' feet at least once every 6 months and ask them the standard history of, if they have got loss of protective sensation, how their foot, if they got any symptoms of, or signs of autonomic dysfunction, then advise them to moisturize their feet, examine their feet every night before they go to sleep, and make sure they feel the temperature. Ask them not to use very hot water or very cold water to have a shower or to soak their feet. Perhaps educating the family as well to detect any blisters or break in the skin or any redness or edema. All these should be looked for both by the clinician and by the family members and the patient. So the basic thing is to educate the patient regarding the foot complications that can occur. Ulcer is one of the late stages. Ulcer and gangrene is late stages, but we should be able to pick up at-risk foot and prevent an ulcer from happening. And if there is an ulcer, we should promptly treat it either with antibiotics or improving the peripheral circulation, making sure the glycemic control is good, make sure that they've offloaded their foot so that there is no constant pressure on the ulcer. If there is a callosity that needs to be removed, if they're wearing the wrong footwear, that needs to be changed. There should be an appropriate MCR footwear that would accommodate the ulcer or that would help with their Charcot's joint. So all these needs to be addressed when we are managing a diabetic foot, either at risk or a high risk, or a patient who has got an active foot ulcer. This goes beyond just improving the glycemic control or using a statin blood pressure or an aspirin or a clopidogrel to improve the peripheral circulation. So it is kind of a holistic care where just the endocrinologist, diabetologist may not be able to manage this patient promptly. So we need support from a plastic surgeon or general surgeon with interest in diabetic foot ulcers. We need a very good orthotist to assess and modify the footwear. We need a podiatrist if we can find one, so who will be able to debride the ulcer or the callosities. So we need a very good team who will be able to communicate well with the patient and prevent ulcer, or if there is an active ulcer, to help heal the ulcer. So it is more holistic care. We need a multidisciplinary team approach to managing a diabetic foot ulcer or a deformity. Thank you very much for your patient listening.
Thank you, Dr. Vidya, for a very detailed review on diabetic foot. I hope our audience will learn a lot of new things from your deliberation. So we have a few questions for you. So you might be seeing a lot of diabetic patients. What are the risk factors that you see in your patients, and what advice do you give your patients to prevent foot ulcers?
The high risk patients or patients definitely the ones with peripheral neuropathy. Smokers are at higher risk because of peripheral arterial disease. Patients with peripheral vascular disease, patients with any kind of foot deformity, those patients are at risk. Patients with motor neuropathy, because they could have the loss of position of the flexors and the extensors, and they can develop claw toes or the hammer toe, and that could lead on to ulcers at the pressure points. So any kind of foot deformity we need to look for actively. Always examine the sole of the feet to look for callosities or corns or flat foot. These are again risk factors for ulcers. There are foot related risks, patient related foot related risks, and the general risk. The foot related risks is all this that I have mentioned about peripheral artery disease, foot deformities, and loss of protective sensation. Patient related factors, or patients generally who don't care for their feet in general, who walk bare feet, are at higher risk. Patient who follow kind of certain kind of rituals. There is a patient who always soaks his feet in hot water every time he before he goes to bed. Those kind of habits we need to change. Patients who walk bare feet, loss of protective sensation, but walk bare feet to temples, yatras, like I mentioned. Patients with chronic kidney disease, patients who are on dialysis are again at very high risk of developing foot ulcers. So those are smokers, as I mentioned before. These are the patient-related risk factors that we should be looking into.
Uh, you talked about pathophysiology of foot ulcers during your presentation. Um, are these ulcers site specific? Like we understand that most of the ulcers are neuroischemic ulcers, but just looking at the site, can we delineate that these are more of ischemic nature rather than
Yeah.
neural nature?
So ischemic ulcers usually happens at the end, the tips of the toes is where we usually find the ischemic ulcers, and they usually have a very clean kind of a margin. We could find a clear demarcation. It's not usually very sloughy. It's usually dry. But with peripheral neuropathy, they can happen at the pressure points. They have a kind of undermining edge. They could have a necrotic base. They could have a surrounding callosity around the ulcer. That kind of proves that's probably the pressure points. But there's also a category where it is neuroischemic ulcer, which can happen at the peripheries where there is a friction, but not exactly. It's a combination of the two, but mostly occurs in the peripheries, but can also happen at the pressure point. So it's an ischemic, neuropathic, and neuroischemic. So the sites are definitely different and will give us a clue. And as I mentioned, 50% will have a combination of neuroischemic element to the cause of ulcer.
Yeah. Thank you, Dr. Vidya. Are there any guidelines? How frequently should we look at the patient's feet uh, in
Okay,
type 2 vis-a-vis type 1 individual?
in the Indian scenario, I would tend to look at our patients' feet at every opportunity that we get. So every visit they come, as I said, my patients don't sit across the table, because then I tell them I can only see them the half the body. So they always sit onto my side, so I can visualize their feet from head to toe. I can see them, and I basically look at their feet at every visit. So there are several guidelines of when you should be examining patients who are on dialysis, who are at high risk like CKD, who have got active ulcer, who have got deformities, but minimum every 3 months. And patients who are at very low risk, we can delay to every 6 months.
Thank you, Dr. Vidya. How important is glycemic control? One of the most frequently asked question is, even if my patient is well controlled on OHA, do I need to put him on insulin because of foot ulcer?
If the patient has got very good glycemic control, I don't usually put them on insulin unless it's really needed or the patient gets admitted for sepsis or wound debridement or procedure. I don't usually put them on insulin. As long as their glycemic control is very well controlled with a HbA1c of 6.5 at the best or less than 7, then there's no real need to actually put them on insulin. But there is some evidence that DPP4 has got an upper hand. But most of my patients, as long as their HbA1c is in the target that we want them to be, and there is no glycemic variability, we don't have to put them all on insulin.
Any red
But
flags on SGLT2 inhibitors?
they used to be with canagliflozin. There was reports of increase in amputation, lower extremity amputation, but then the subsequent studies have shown that there is no real evidence linked to SGLT2 inhibitors, so the FDA has taken out the black box warning. But it's something for us to keep an eye on. Yeah.
Yeah. So this is what we also practice over here. It's really hot where I live, and dehydration is one thing that I'll specifically like to prevent in these patients. So we do tend to withhold SGLT2 inhibitors, especially during the summer seasons in our foot patients. So this is what we do. We do keep a watch when we if we are giving SGLT2 inhibitors. Any preventive strategies as far as if my patient has developed foot ulcer, how can I prevent amputation in that foot? What should I advise to my patient?
Okay, so it depends upon if it is a chronic ulcer or an active ulcer with cellulitis or gangrene, and depending upon various factors, like there are the Sinbad, there is various stages there is of classification, and depending upon where actually their stages actually. If there's a chronic ulcer, then perhaps a good footwear, good glycemic control, offloading the ulcer. If there is a surrounding callosity, then removing the callosity will help healing of the ulcer, provided the vascular supply is good. So you need to have good blood supply, the nutrition should be good, the glycemic control should be good, and we should be able to offload the foot. If the patient is constantly walking on it, then it's not going to heal the chronic ulcer. But with active ulcer, we need to stage it to see at what stage it is. It's a small ulcer, or is it has it got cellulitis, or is it the stage of a blister? Is it at risk, or actually an ulcer, osteomyelitis, gangrene? um, then depending upon that, then we do further investigations. As I said, we'll have to look for peripheral arterial disease, and if there is a significant compromise, then we'll have to revascularize. Unless we improve the vascular supply, no matter what antibiotic you give or you improve the glycemic control, the ulcer is still going to be an active ulcer. So we'll have to get the interventional radiologist involved, perhaps an orthopedic surgeon with interest in foot ulcers, or a plastic surgeon. In my hospital, the plastic surgeons are more than happy to do active debridement, and we get the interventional radiology team involved to see if we can improve the peripheral circulation. And then all these are going to help, and antibiotics if needed, if there is cellulitis. All these are going to help an active ulcer to heal.
And thank you again, Dr. Vidya. How important is patient education in this regard, and
That is
their
the most
education?
most important is patient and family education. Even during the presentation, I kept reinforcing that one of the reasons why the ulcers don't heal is the patients expect a miracle. The ulcer happens and the patient feels, oh, they will have to keep on coming, and then the ulcer is not healing. You gave antibiotics, you debrided, it's not healing. Because one of the reasons why it's not healing is they're not adherent to the advice we
That
give
is
them. Perhaps they're not able to adhere to the advice because they might be the only earning member of the family, and they'll have to stand and do the job like a security or a police personnel. They're not able to actually offload their feet. But those are the patients will have to find out why they're not able to adhere to the instructions that we give them, and why they're not able to offload their feet. So those are the patients we'll have to provide special footwear such that they wear the footwear and they can still stand or they can walk, but with that footwear which will help offload the foot. Second is very good glycemic control. I keep telling them, unless we get the glycemic control good, no matter how much dressing we do or antibiotics we give, it's not going to get better. And the infection will keep on coming. It tends to close, the wound will look like it is healed, but it's quite undermined underneath. What you see is not actually what is happening underneath. So it'll look like it's healing, but it'll keep on recurring if the glycemic control is not great. And even if the ulcer has healed, as the statistic shows, a higher chance of ulcer, diabetic foot ulcer recurring in a patient. The chance is about 64%. So it's not the end of the game, even if the ulcer is healed. So educating the patient and the family is very, very, very important. And we do that all the time. So we do that. That's part of the consultation, is educating the patient and the family. Tell them it's going to take its own time. But if you don't do all these things, it's going to take longer.
So yeah, absolutely right, Dr. Vidya. So there are certain situations like CKD with the diabetic foot, or the patient is post-transplant on immunosuppressant. So that makes life a bit difficult. How do you manage these patients?
That's a very good question. Patients already who got chronic kidney disease and who are on end stage renal failure on dialysis are at higher risk of diabetic foot ulcer. And these are the patients that the guidelines suggest perhaps we need to examine their feet every month or every opportunity get, but minimum is every month. Again, the basics, hydrating the skin and preventing an ulcer from happening. And also look for loss of protective sensation and peripheral vascular disease in these patients. And if there's any chance we could revascularize their feet or prevent an ulcer happening, that's the best thing we can do for these very high risk patients. But once an ulcer has happened, then it becomes tricky, because again, the first part would be to prevent the spread of an infection, prevent it from going deeper, because already the patient is immunocompromised. For example, post renal transplant patients, I use antibiotics because I don't want it to interfere with the TAC levels or anything. But I look at the diabetic part and ensure that the control is as good as it can be. And as said before, I involve the plastic surgeons if it is deeper. We have an very good nephrologist who manage their own antibiotics, according to the antibiotic policy, but very good glycemic control. I have a couple of patients who have lost their foot because they developed Charcot's arthropathy, and they ended up having a lower limb amputation. There are two of my post renal transplant patients who ended up having a lower limb amputation despite doing what we have been doing.
Yeah, so definitely a difficult situation to manage post transplant diabetic foot, because we have to take care of a lot of things. The patient is on steroids, his glycemic control is fluctuating. Yeah, it's a difficult situation. You did talk about role of radiology. How frequently do you use angiography, maybe conventional angiography also, and nuclear scans in managing diabetic foot complications?
I'll answer the second one. I don't usually use nuclear scans to look for this white cell scans, tagged ones to look for osteomyelitis. We do MRI to look for if there is a doubt of osteomyelitis. We do MRI. If it is not very obvious on an X-ray, then we go on to do MRI. We don't always do MRI as a first line. Chronic ulcers, we always get an X-ray, and if there is a break in the cortex, then we assume that it is osteomyelitis and will need chronic antibiotics, and MRI. But peripheral vascular disease, I always examine the patient's feet for good peripheral circulation. But if I have a doubt there is a neuroischemic element to the ulcer, then I'll involve the interventional radiology team to get an angio done on them.
That does make sense. Uh, nutrition, I believe, is the most important thing. And just a few words on nutrition for our viewers, because I believe that without good nutrition, it's really impossible to heal the ulcer.
Yes, we'll have to make sure that they're not anemic. Make sure we correct the anemia. Look at the albumin to see, that's one of the markers of poor nutrition is if their albumin is very low, then get that corrected. They obviously their glycemic control should be very good. I usually put them on a very high protein, low carb diet. Correct the anemia. If they've got B12 deficiency, then correct those. I don't usually give protein supplements just for the sake of healing, ulcer healing. But generally, Indian diet is very poor in protein. However hard they try, but I encourage the patients to go on a very high protein diet. Some of them go on 3, 4 eggs in a day. I encourage them to have just up their protein intake, but looking into their hemoglobin and perhaps their B12 and albumin, these I feel are pretty good markers of nutrition in our Indian patients. Those are simple tests that you can do to detect their nutrition. First, getting a good history about what they actually eat on a daily intake and their weight, and if their BMI is too low, then those are the things to address.
Yeah, definitely, Dr. Vidya. So I remember one of my teachers, Dr. Amini, telling us that it is one situation where you should not hesitate in writing a multivitamin to your patient. Just do put in a multivitamin, and do put in a, because many of our patients, more than 90% of our patients are anemic, especially those who develop diabetic foot ulcer. So these were the two things she always impressed upon, and I do remember those teachings from her. Dr. Vidya, thank you for a very wonderful session. Any last words for our viewers? Any last comments on diabetic food for our viewers?
Well, I think it's prevention is always better than trying to find a cure for diabetic foot complications. So we should always examine our patients' feet in every clinic, every opportunity that we uh, get. And COVID has taught me a good lesson. Is like we patients used to come, and then as soon as they enter, they used to sit across my table. And because then I started maintaining distance, and I asked my patients to stay away from me, sit away from me, and they kind of got used to sitting away from me, still facing me. In that way I can examine their feet, and I have many a times picked up autonomic neuropathy, motor neuropathy, and ulcers, because the patient often forgets to tell, and they often get up and go on their way out. They will tell me, "Oh, by the way, I've got a blister, or I've got an ulcer," or they would have told my secretary or my nurse, and they would have assumed that they will pass the information on to me. Making them sit in a way that I can see them as as a whole has helped. So we need to examine. Unless you ask, they're not going to tell about burning sensation, numbness. Burning sensation they often say, but they don't tell the numbness or the small blister. you know they often think like, oh, it's as long as it heals, they don't have to mention. So we'll have to proactively ask them history of loss of protective sensation, and examine their feet every opportunity that we get. And my physician assistant, she's very good. She always asks for retinal screening, their feet, and their diet and alcohol and job and everything. So everything is kind of written there, and I just need to reinforce that feet is as important as their eyes. And I keep telling my patients, whenever I see your feet, they should be like nice and well moisturized, just like your face. So don't ignore your feet. They should be nice and clean, and you should look after your feet just like how you look after your face. So then the patient gets that idea is they can develop problem with their feet. So we'll have to keep on telling them that feet is as important as your eyes or your kidney, and you can develop problem with the feet. So patient education and us being proactive in looking for the smallest signs of peripheral vascular disease or peripheral neuropathy is very, very important. First is prevention, detection and prevent it, and then once it happens, then obviously treat appropriately.
Thank you, Dr. Vidya, for a very nice message. And I believe prevention is better than cure. And this is one of the situations where this sentence holds absolutely true. If you are able to prevent an ulcer, your patient life will be much better. Thank you, Dr. Vidya, for a very nice session. It was pleasure of having you here for this meeting. Thank you. And now I'll hand over the session to the organizers. Thank you.
Thank you, Dr. Atul.